Cambodia, a country with a traumatic recent history. Between 1975 and 1979, the Khmer Rouge decimated almost a quarter of the population through a regime of terror. The totalitarian experiment destroyed much of Cambodia's infrastructure. By 1979, fewer than 40 doctors were left in the entire country. The public health system effectively wiped out in a span of 5 years. The newly established Cambodian province of Pailin, 2010. In the former Khmer Rouge stronghold, economic development is still in its infancy. Morbidity and mortality from diseases such as malaria have plagued the countryside. Since the 1970s, Pailin and the border area between Thailand and Cambodia have been ground zero for the emergence of drug-resistant malaria. At present, there is evidence that the last effective drug against the virulent strain of falciparum malaria, called artemisinins, is also beginning to lose its effectiveness. Since 2007, the World Health Organization, donors, and national stakeholders have developed a strategy to contain this deadly drug-resistant malaria at its source. This containment project is supported by the Bill and Melinda Gates Foundation and the Global Fund for AIDS, TB, and Malaria, with technical guidance from the World Health Organization. A major effort has been underway to contain the disease, mobilizing massive amounts of human resources and an arsenal of disease-fighting commodities.
We have divided the area in two zones. Zone 1 and Zone 2. Zone 1 we have 4 provinces. These 4 provinces we have around more than 200,000 population. And Zone 2 we have 9 provinces, more than 4 million population. So the province in Zone 1 is a very important area where we strongly control. We provide all our material equipment, medicine, and our deploy the people also in this Zone 1. That's why we can see the very good result in this area, that no counterfeit drugs, and the cases reduced. And like you can see, largely in Thailand, as considered as Zone 1, is no deaths in this area.
One tool that's been effective so far, and I think it's being proven as we speak, is the supply and training of people at the village, volunteers at the village. We call village malaria workers, or VMWs. And these VMWs take it upon themselves in their villages to diagnose and treat people in their village with an RDT, a rapid diagnostic test, which they can easily perform using a pinprick of blood. They can see whether the person has malaria or not, and provide free diagnosis through the RDT and treatment for the patient. And that's been very effective.
Village malaria workers are used on the front lines at the village level as a key component of the containment project. They also provide essential and up-to-date reporting to the national program about the incidence of new infections and where they are occurring. Besides the local villagers, the project targets hard-to-reach, vulnerable populations such as migrants and mobile agricultural laborers. These groups are at high risk of malaria due to their proximity to forested areas, which are prime breeding grounds for the anopheline vector. The containment project isn't trying to reinvent the wheel. Tried and true tools which are effective for malaria control are utilized, such as long-lasting insecticide-treated bed nets.
Actually, we've talked a lot about drugs and testing, but the way you stop malaria is by preventing people from being bitten by infected mosquitoes. And it's certain mosquitoes that are nighttime biting that transmit malaria. The bed net itself does provide a physical barrier against the mosquito. But in addition, the bed nets that we're distributing, we've distributed half a million nets already in this project, are insecticide treated, which adds an extra level of protection by either killing some mosquitoes or driving others away by a repellent effect.
In focus screening and treatment, the containment team tests everyone from the 10 most malarious villages. After recording detailed patient information, villagers have their temperatures taken, and anyone who is symptomatic or is suspected of having malaria will be tested with a rapid diagnostic test, also known as a dipstick test. A pinprick blood sample is taken, which will be used in the dipstick test, microscopic analysis on blood slides, as well as for molecular analysis using PCR. Someone testing positive for malaria will immediately begin treatment under direct supervision by the malaria workers, including follow-up treatment for the next 3 days.
The PCR can find, theoretically, any parasite in the blood sample. What we're trying to do is find every last hidden case of malaria, even if they're asymptomatic.
A crucial piece of this puzzle is ensuring that the life-saving antimalarial medicines are of the highest quality.
We're very concerned about the quality of anti-malarial drugs at this point because they are driving in this region the emergence of artemisinin-resistant falciparum malaria. That is, the continued presence of artemisinin monotherapies and substandard drugs are providing selection pressure for resistance, which is creating the problem of the resistant parasites.
The private sector is still providing substandard and even counterfeit drugs. But the government of Cambodia has installed justice police who inspect all the outlets on a regular basis, and they do inventory and stock checking, and we're already getting anecdotal evidence that this is having an impact. It's not perfect. You know, it's not as if one day it's bad and then you flip a switch and the next day it's good, but I say the situation is getting much better. The justice police are, through a carrot and stick approach, are providing the penalty if outlets don't comply, but they're also providing encouragement of doing the right thing. We're in a very good situation right now because we're properly resourced to take all the necessary steps to eliminate transmission of malaria. Now, I don't say that right now we've eliminated malaria, and I don't think we'll do that in the next 5 years. I've been in this game long enough to know that anything can go wrong. But when you put the proper tools in the hands of people who know what they're doing, which is happening here in Cambodia, give them enough resources, and by that I mean the money to go out into the field. You need boots on the ground, and you need wheels on the road, and you can't do it otherwise. And that's what's happening right now. We've got the pieces in place, and we're going to be able to spread it all the way across the country from west to east, and I expect that we're going to see results.
We've reduced malaria substantially in Zone 1 and Zone 2, and these efforts have been recognized, and I think basically round 9 Global Fund funding will come in and provide support to the whole country.
In general, in 6 months of 2010, you can see the deaths only 38 deaths compared to 2009 is 138. And the cases, you know, confirmed cases, just as I said about confirmed cases, less than last year, 5,000 cases. You know, so that is talking about the control of mortality, morbidity is a very successfully, we should recognize that.
I'd like to finish by saying that this issue of artemisinin resistance is a major problem. And we, as WHO, are working with the countries, with Cambodia, with Thailand, with other countries in the Mekong region to aggressively tackle this problem. Obviously with the support of a lot of partners, with the Bill and Melinda Gates Foundation, with USAID, with DFID from the United Kingdom, all working together to support the countries in their fight. There are some worrisome signs that resistant parasites have emerged elsewhere in the Mekong region. Those problems appear focal, and they don't appear to have overall undermined our efforts at using ACTs. And there's no evidence at all that the problem has spread to Africa. So I think the take-home message is that while this remains a public health urgency that we need to respond to, and we need to make sure we contain this and ultimately eliminate these parasites, that there is not a reason to throw our hands up in despair and act as if we've lost our most powerful tool, because in most places that tool remains highly effective.